Good morning, everybody. Over the decades, lot of randomized trials have been published and meta-analysis also. Everybody else we know that is for ST elevation myocardial infarction, the gold standard of treatment is primary PCI. In all respects, the mortality, morbidity, the LV function assessment, and the short-term and long-term, everywhere the PCI has got a important difference over and above the thrombolysis. But time is an issue. At what time the patient, if the patient comes to us, at what time we will be able to do PCI or not, that is a very important issue. So two important things, one is timely, another is late. So what is the definition of timely and what is the definition of the late presenter? So how late is too late for primary PCI, that is the important issue. But the STEMI, the 12-hour cutoff, everyone of us we know that this 12 hours is the guiding time. If the patient comes after 12 hours, probably PCI or any sort of thrombolysis is probably not going to work. Now, how this 12 hours time came to us? Why we believe that this 12-hour time is important? Now, late presenter is a very important thing. How many patients of us are late presenter? I am showing this published in American Journal of Cardiology in 2021. This is a Korean study from the 2011 to 2015. You see that 89% of the patients, they arrive in the hospital within these 12 hours. Only 11%. Is it the scenario in Bangladesh? It's not. We don't have an effective registry, but we know the scenario in our neighboring country, India. In 2022, India has published a nationwide guideline for the treatment of ST elevation myocardial infarction, and they have written in the 2 lines, everything has written within 2 lines, they have written more than 50% of the patients in their country do not get any fibrinolysis or primary PCI as they arrive in the hospital after 12 hours and then after 48 hours. So that they do not get the effective treatment. So we don't know the actual scenario in our country, but it is not, I think it should be equivalent to India also. So we cannot compare the late presenter in our country with Europe and Korea also. So how we know that the 12 hour is the cutoff time? This definition, 12 hour, was taken 30 years back, publication of the late study in Lancet in 1999. They found that if the fibrinolysis is given after 12 hours, it is not effective. So is it still valuable in the era of PCI, primary PCI? Probably not. ISH2 was published in 1988 in Lancet, and most of the studies were done on the animal model, 6 hours for the animal model and 12 hours for fibrinolytic model. So in the era of PCI, is it the same time as we should adopt this time? Now you see what the recommendation is saying. The recommendation in ESC and recommendation of ACC is little bit different. Now if you look at the one slide only, if the patient comes within 12 hours of the development of the HTMI, straight away patient should go for PCI. Now if the patient comes within 48 hours, the patient is having ongoing symptom, hemodynamic instability and arrhythmia, definitely again the patient, there is no time bar if the patient has got ongoing symptoms. But what is the problem is that if the patient comes after 12 hours and he is asymptomatic, HT has come down, everything is okay. So what to do? Now the ESC recommendation is that if the patient comes with 48 hours of inception of the HTME and the patient is asymptomatic, ECG is okay, even then the patient should go for primary PCI. It is a class 2A recommendation. But if the patient comes after 48 hours, the routine PCI of the IRA is not recommended. So this is the same thing I showed you. We look at the third one. A routine PCI strategy should be considered in patients presenting with 12 to 48 hours after symptom onset, but it is a class 2A indication. An asymptomatic patient, routine PCI of the occluded IRA is contraindicated. It is the class 3 recommendation. Now, ACC and ESC is somehow different. Now, I show you what is the difference. If the patient comes within 12 hours, there is no difference. But if the patient comes after 12 hours, it is different. Now, the ACC recommendation is that if the patient comes after 12 hours, but if the patient is in the hospital within 12 to 24 hours, then it is a class 2A recommendation. So this recommendation in ESC up to 48 hours. So ESC advised if the patient is present within 12 to 48 hours, if he is asymptomatic, the PCI should be done. But in SEC, it is 12 to 24 hours birth time. Now, PCI in the late presenting STEMI, how late is too late? Now, late presenter are this challenging group to manage. Presentation vary considerably from those with ongoing chest pain patient may have, or patient may be absolutely asymptomatic when presenting after 12 hours. Now, how should we manage the late presenting STEMI patients with hemodynamic instability? There is no time bar. Any patient with a STEMI coming with hemodynamic instability, acute heart failure, straight away patient should go for primary PCI. How should we manage the late presenting STEMI patient with ongoing ischemia? Here is also, there is some difference between ESC and SEC. The ESC advised that is patients presenting after 12 hours with ongoing ECG changes and symptoms of ischemia, a pre-PCI, primary PCI strategy should be adopted. But SEC limits the time 24 hours. So it is the difference between the time. The SEC is 24 hours and ESC is 48 hours. So what is the rule of PCI in the late presenting patient without ongoing ischemia? This is the problem. If the patient is absolutely stable, ECG is okay, then what to do? The BRAVE trial was taken in 2014 and 4 years follow-up was also published. These patients were totally asymptomatic. The BRAVE trial shows composite of death, recurrent MI, and stroke at 30 days was more common in conservative group. So primary PCR is still valid in this sort of patients who present with 12 to 48 hours onset of patient. The patient is asymptomatic and the ECG is okay. Even then, patient should go for primary PCI. The Korean registry also shows that no primary PCI strategy was significantly associated with increased 180 days mortality. So the primary PCI is better. Now, does PCI in late presenter affect LV function? Now, overall data from imaging studies appear to indicate that reperfusion is associated with improved LV function. Now, the DECOPI trial was also found that the LV ejection fraction was 5% higher in PCI arm. Now, DECOPI is very old trial. This was published in 2004 in New England Journal. This is basically, DECOPI is a French and Belgium study. They showed that these patients get benefit even PCI is done later. So, and this DECOPI also, one of the inference of DECOPI that the patients with occluded coronary artery after 48 hours should not be opened up. So it is one of the important features from the DECOPI trial. Now, ease of time, this, in the era of PCI, data on the 12-hour limit is inadequate in the modern era of PCI because these studies, those who are telling that the 12-hour is the cutoff period, they were taken on the animal model and 30 years before, that's first published in 1993. Now, FAST-MI is a French study. A total 6,273 STEMI patients they randomized, and 67.7% are revascularized within 48 hours of hospital admission. Now, if you see the result of the FAST-MI, the 30-day follow-up all-case death rate was significantly lower among revascularized latecomers, 2.1 versus 7.2%. So clearly there is a benefit of PCI, the primary PCI. And it is almost triple, 2.1 versus 7.2. And 58 months follow-up also shows that the primary PCI is better than non-PCI. Now, this is a very new article published in Catheter and Cardiovascular Intervention in 2023. They compared the effectivity of PCI 12 hours versus 24 hours. And they have shown that less than 3 hours, 3 to 6 hours, 6 to 12 hours, and 12 to 24 hours. Now, if you see the result, 1 year death rate was comparable between the late and early presenters. So it's the same. If you do the primary PCI 12 hours, you do after 24 hours, the result is almost same. Despite the unfavorable risk profile and longer dose to balloon time, clinical outcomes of late presenters were similar in this presenting patients within 12 hours of time. So it is, this article is published in this year, over 6,000 of the patient presenting with the HTME within 12 hours and 12 hours to 24 hours window period. Now, what evidence says? Evidence suggests that the PCI offer a mortality benefit when performed up to 48 hours of symptom onset, with benefit demonstrated in asymptomatic patients as well as those with ongoing ischemia and cardiogenic shock. I want to clear one thing. If a patient has got STEMIs, if a patient has got ongoing ischemia, the ECG shows dynamic changes, the patient has got acute heart failure, patient has got life-threatening arrhythmia, and the patient has got cardiogenic shock, time is not a bar. There is no question of late. This patient should go for primary PCI. Now, problem is if the patient is asymptomatic. Even if the patient is asymptomatic, if the patient, according to the ESC, if the patient comes to hospital within 48 hours, this patient will also go for door and needle time is not a problem in this sort of patient, because the CAMIR NIH, they have shown that the door and needle time is not a very important issue if the patient comes after 12 hours. So this patient should go for primary PCI. Now, beyond 48 hours, one thing we should remember, beyond 48 hours, the recanalization of occluded coronary artery should not be done. It is a class 3 recommendation and may do harm. So after 48 hours, if we do the coronary angiogram and the artery is occluded, that artery could not be opened up. And this, on the basis of the 3 important trials, the OAT trial, the TOSCA-2 trial, and DECOPI trial, all these 3 concluded that opening up a totally occluded artery after 48 hours is not beneficial and probably harmful, because the chance of getting reinfarction and death and retardation of the LV function is common. So it should not be done. In all the ESC and ACC, in this respect, they are same. They are telling this should not be opened up. Now, there are studies that are coming, already published. These are not on the angiographic basis, but they are doing the SPEC and the CMR. On the CMR basis and the SPEC study are showing that if primary PCI can be done within 72 hours also, this is also beneficial for the patient, at least for the LV function. They are telling that this image-based studies are showing that these patients are definitely getting benefit, not equivalent to the benefit if the patient comes within 12 hours. Even then, they get benefit if you compare them with the conservative arm. So now the articles are coming that the 72 hours also is not a late presentation for the patient with ST elevation myocardial infarction. So I finished my lecture with one thing. This is an editorial comment in 2023 in the Catheter and Cardiovascular Intervention. It is written clearly that the author has written that PCI for late STEMI, better late than never. Thank you.